we not able to do analytics? Why are we not able to do data decision making? Because one malaria, for example, I'm not a doctor, somebody writes another complicated names using ICD-10 codes. Another one writes another complicated name. Another one writes malaria. For all systems to work, all of us must have one terminology. So that's another registry. One language in a simple word. Kenya was to move to ICD-11, I think this you can confirm, around 2012 or so. As of today, most of the facility was still in ICD-10 until we built the superhighway. Everybody is rushing now to move to ICD-11. Better treatment for Kenyans and alignment with WHO standards. That is another whole system. Community health systems. All our CHPs, giving them devices, making them to refer. When they go to your homes today, they collect that data. How does that data move to your hospital? So that they are then able to help you in referrals. That's another whole ecosystem in the highway. Finally, your virtual file. You used to have books. You used to go to hospitals and have to explain your historical treatment. With your virtual file today, you are able to have your information in Afya Yangu. We're able to store your virtual files in a secured location so that when you give consent, the doctor is able to access it, but only when you provide consent. That is the core of the highway. Move to logistics. Those are the systems, so that people don't say that the one of is for sure. Move to logistics. Track and trace. You saw a publication by PPP where we are telling everybody who manufactures drugs and brings them to Kenya must register it in a track and trace system to remove all the fake drugs, to give safety for Kenyans, and enforce proper standard to it. So the whole of track and trace system, the whole of ordering management system for our facilities not to order what they don't require. For data to tell them you don't need to order this amount or you have these ones. I'm sure I saw a lot of reports of saying expired drugs. Why do drugs expire? Because you think you need 20, but actually you only need 5. All that logistics ecosystem, we're digitizing the whole of it, from the facility to the manufacturer. Do I continue with many others? There is telemedicine. There are so many. Right. But more importantly, the Kenyan government is not paying for what has not been delivered. That's why you don't see it. You pay for the service you deliver. So when all that is finished and all the system are in place, we ask what has been delivered, what are we able to see, and what services do we receive? That's why you don't see a contract of 1 or 4 in a budget of Ministry of Health or anybody else. It's fee for service.
Thank you.
And when you have time, come to my office, I will explain to many others. Telemedicine, we have not talked to another 38 of them out of the few that I've said. Thank you.
Thank you. Born engineer, I see you've become a doctor. ICD-11 is the International Classification of Diseases. So it's the universal language of identifying the diseases, so that I don't say complicated malaria, I just put a code and it speaks to the system.
Thank you. Thank you very much.
Kemsa.
We had a flow of that, but let's go to Kemsa.
Thank you very much. My name is Dr. Wako Dulacha. I'm the CEO of KEMSA. This is a very good opportunity. Now, mine was a disconnect between, an alleged disconnect between the 94% and what is in the facilities. But let me give you a story about how we reached 94% in less than 2 years. 2 years ago, we looked at the products that are stocked in KEMSA and what KEMSA has been struggling to buy. And we call those stock keeping units, SKUs. So when we looked around and took a stock, we realized KEMSA is chasing 3,800 SKUs. Then I asked my team, do counties and our customers, the facilities, do they really require all the 3,800? How can we consolidate our effort with the little resources we have? And we buy SKUs that talk to the needs of the customers. Because when you look at our core values, every organization has core values. You always talk of customer-centric. So you have to talk to what our customers really require. Then I talked to my team, the relevant teams, the entire KEMSA team. I took them out for a week, go and talk to the systems everywhere and see, do we need the 3,800? Then they came up with what is required. 485 is what has been ordered over the last 5 years, out of 3,800. So we said, do we really continue buying this? Then we said, let's corroborate this information and call in the 47 county pharmacists. They all assembled in Naivasha. We asked them, what are your requirements? What do you really need for us to buy for you? Because we are serving you. And they actually confirmed that that is what they require as essential medicines and medical supplies, the EMMS. Then we said, now, if we're chasing, it's a very different game to chase 3,800, and then that leads you to another fill rate of 38, 40%. It's a different ball game to chase 485, and that is the magic that put us to 90%. I'm not saying we stopped buying the entire 3,800, but we decided to consolidate our effort to what is required by the country, what is required by our public health needs. Yeah? So I must confirm here that our order fill rate is 94, it's over 90%. Now, that is KEMSA. KEMSA has two business models. One is what I call, or what we call, not me, supermarket model. So we buy and we sell. It's a big supermarket of health products. So we buy and the facilities buy from us. The other one is the supply chain. You heard of the Prima Queen and other products that the ministry and development partners give us to buy. So there we earn supply chain fees, and there we are under instructions to buy. So if the ministry wants Prima Queen, they tell us to buy. If it's not out, I know you don't know, so you'll say KEMSA is at fault. So I think it's good to learn what is in our business model to the supply chain and what is in our essential medicines and medical supplies called EMMS. For EMMS is what we talk about, the order fill rate, which is over 90%. So now we have that at our KEMSA. Now what happens is, do the facilities order? And it is not for free. KEMSA has stopped being a push system. It's a pull system. You must order to buy. It must be a request from you. That's why it's called an order fill rate. So the counties, when you hear that maybe they don't have stocks, it is them who have not ordered from us. There's erratic order from them. One, maybe because they do not have the funding to buy from us, or they are shying away because they have a lot of debt with us. So they keep flip-flopping through meds and us. They owe this, they go to meds. So then you start seeing erratic supply at the health facility level. So our assurance as KEMSA is, let us remove this syndrome of Hakuna Dawa. It's a change management again to our wananchi, that automatically the default position is Hakuna Dawa in the head. Kenya, please remove Hakuna Dawa. There's Dawa in KEMSA. Thank you very much.
Thank you very much. Indeed, there is Dawa. Kuna Dawa KEMSA. And, Waziri, when I was listening to the CEO, he took his whole team to Naivasha for a workshop to make sure that they understand what it means for safe supplies, make sure there is steady delivery of real safe medicine and also vaccines. Asante sana, another round of applause. We are fixing and reforming the health sector. And that is why we are equally here today to explain to you what it actually means. Because it is not just about giving money to facilities, to damaged hospitals. It is also about fixing the whole system to work for everybody and to be stronger for the future. When we look at the same, what does it mean? It means working together, county government and national government, holding hands together. It means also building a stronger foundation. It means the focus should move to local clinics first. It's not just about building the bigger hospitals, but it is also.
Give to this girl to ask questions.
It is also putting money first in the small local facilities. And that is why the COG is here to explain to us about the service delivery. Mary.
Maswali. No, Maswali.
There was a question for Mary.
Okay.
Yes.
But we want to ask, I want the media to ask all the questions.
Okay, and I can.
This is their day. It's not us to talk.
And I see requests for media wants to do interviews after this. Please ask all your questions here as directed by Waziri. There'll be no side interviews. So all your questions here, Waziri has directed us so that all his team members here can answer.
Thank you very much, Mercy and the CS. And I think every day is cool. Yes. Seated here, I have learned a lot of things that I didn't know. Our wish that the narratives that is being received, because it's verbatim, it is authentic, will influence our reporting moving forward. And the reason as why I always say that media is one of the strongest allies of government and any successful institution is for them to be able to shape the narrative to a common mwananchi. Hiyo tunaambiwa tusomoe hakuna dawa, kuna dawa can only be done by the people that are seated here. There was a question from one Mercy that asked whether county governments have fully embraced health as a devout function, and this was in relation to human resource engagement, hiring, and equipping of the health facilities. I want to specify first that the health digital reforms have actually worked and transformed the health architecture of this country. I say again, I stand testament CS that the digital transformation agenda has actually worked for this country. The fact that we can convene the facilities in charges 30 minutes and they are able to unlock all functions, feedback to both DHA and SHA, for me, digital reforms have actually worked. Now, in relation to fully embracing health, I want to say the 14 devout functions have made considerable improvements in the service delivery to common mwananchi. Health, however, has been fully embraced by every 47 county in this country. And in relation to hiring, I want to confirm that numbers do not lie, that pre-devolution, we had 90 health workforce in this country, that those included nurses, doctors, clinical officers, and midwives. Right now, 2024 report data shows that we are close. We are close to 200,000 employees hired across the entire 47 counties. And for me, devolution is working. I want to give an example of specialized doctors. Wajir pre-devolution had only one specialized doctor. Right now, there are over 79 specialists in Wajir. And I'm just giving an example of one so that we show health has really transformed and the like. When we come to health facilities have grown from pre-devolution from partly 9,000 to over 15,000 health facilities. For me, health is a fully devout function and it is working. The fact that each and every level 5 and level 4 can afford and give dialysis services to the diabetic persons in this country, for me, health is working. That Kenyatta Hospital no longer hosts myriads of people in this country to come and queue for months for them to be dialyzed. For me, health is working. When we come to equipping, and I want to give this accolade actually to the head of state, that realize that county governments, and of course for us to achieve universal health coverage, health facilities must be fully equipped. And he devised and tasked us with the Ministry of Health to ensure that the National Equipment Service Program is actualized, is working, and that every facility gets equipment that they so deserve for purposes of rendering services to these 290. NESP is a program that has complemented the universal health provision in this country. It is a national health service provision, is provision of every equipment that is required for level 3, level 4, level 5, level 6 at no cost of any health facility or any government, any county government. It is actually a fee for service where vendors were identified through a rigorous tendering process, and they were able to confirm that they would actually place every equipment that is required. And for each and every service that each equipment offers, there is a fee attached to it, and that is compounded actually under SHA. So there is no health facility that can actually claim that they do not have equipment to give service delivery to citizens because there's a program that you just get equipment, then for each and every service that is advanced, they recoup back their cost. So in terms of equipping of health facilities, I can confirm through this national equipment service program that is a collaboration between the national government and the county government has actually done wonders, and universal health coverage is actually a real and a true factual statement that health is working in this country. So I believe I've given statistics that cannot be refuted by anyone. Thank you very much, and over to you.
Back to you, Mercy, for another round of questions.
Thank you, Madam PS. There are very many hands on this side, and there's a gentleman here. So allow me to take on this side. Please, if your question has been answered, don't repeat it so that we are incremental unless you're seeking clarification. So let me take the lady here. There's a gentleman there, and then I'll come to you here and at the back, and then I'll come to this side.
Okay.
Yes, we'll take. I'm clearing this side, then I come to this side. Please remember, ask all your questions here. There will be no side interviews after this town hall.
Okay. Good morning, everyone. My name is Helen Shikanda. I'm a health and science reporter from the Nation Media Group. First, I have a comment and then questions. My comment is something that most journalists in the room would feel, and it can be frustrating sometimes to get comments from the health ministry and not necessarily from the CS, but even the SAGAs. And I'll give an example of the Pharmacy and Poisons Board, for instance. I asked a question sometime last month about the status of approval on semaglutide. And I asked it because there was a private company that had introduced the generic version, and the PPB last year had mentioned that the Ozempic pens in the country were fake. So I just wanted to seek that clarification, but it takes more than 20 business days to get that response. So if maybe the ministry can help fasten the process in terms of getting feedback from the different sagas in the country, it would help in the work that we do. And then now to my question, which is tied to the state of devolution report that was released last week, which had great strides in terms of maternal and newborn health, but there was one indicator that was a bit off, and that is on skilled delivery. And when we speak to community health promoters, they say that mothers are shunning away from the hospitals because of SHA. They don't have the money to even pay the registration, and now they're opting to go back to the traditional birth attendants. And I'm asking this question because the country launched the Ewene initiative, and we want to reduce the maternal and newborn deaths. yet mothers are now giving birth away from the hospital. So what can you answer in that regard? My other question is also on the clarification on malaria infections data. Dr. Amoth, you've mentioned that we have reduced the cases, but when you look at the data that we got from the economic survey that was released sometime in April or May, the previous year, 2024, it was about 3.8 million, but the latest data shows an increase to 14.3 million. So I want to know, like, what is the exact number, because that is almost quadruple the numbers of new infections compared to the previous year, and what could have led to this increase if that data is correct? My other question is to SHA. What is the status of pregnant mothers who are foreigners or refugees who do not have IDs and they need to give birth in our hospitals? And for one to register under SHA, they need to have a national identification card. So how can they go about that? What is the status of the fraudulent claims by SHA that the ministry has been talking about? And then another question is on SHA basic services. Some Kenyans are asking why dental services are not covered under SHA, especially the basic ones. So those are the questions that I have. Thank you.
Very good.
Helen, let's just finish with that table. All the hands were up.
Thank you so much. My name is Angela Okech. Angela is the content lead health and science, Nation Media Group. As Bwana Waziri has mentioned, he's one of the officers that has been answering questions. Regardless of how he answers it, he will answer it. However, we must recommend him on that. He will tell you whatever you want to say, but he will answer. But we have a problem with other officers. You will call, they will ask you to send questions, they will not respond. Bwana Waziri, we have a problem getting data in a number of health parastatals. For instance, I'm going to mention this, but I'm sorry. We've been looking for cancer data for the last 3 months. For the last 3 months, we have not been able to get that. We have been looking for data for breastfeeding. We were doing a pull-out on breastfeeding. We were not able to get that. We have been looking for data on menstrual situation and mental. We have not been able to get that data. So when we report what we have, you might say we are not factual, but we are not getting what is factual from you people. So please. My question would go to, I don't know whether Bwana Waziri would answer this or the CEO, COG. It's about the National Equipment Service Program. You've talked about counties getting the latest equipment, even as far as Lamu. However, we are having a problem. I don't know what was the agreement between the contractor, because a number of hospitals are mentioning there is a breakdown in the equipment, but they are unable to fix it because the contractor apparently was not on the site. So I don't know what was the agreement between the contractor and the person who brought the equipment to the county hospitals. A case in point, I know Bwana Waziri will tell me, Angela, give me the example of hospital you are talking about. I'm talking about Jaramogi Oginga Odinga. Please find out about the equipment that is there and which contractor was in place and why the equipment is not working. My second question would go to, we've had a problem, or rather, we've had donor funding cut. We are seeing HIV cases, the new infection increasing. However, we are doing so well when it comes to deaths, whereby we are seeing more deaths decreasing. But what plans do the government have to ensure that we reduce the numbers when it comes to new HIV infections, and are we having allocation in that sector? Secondly, we are talking about, Waziri, you've talked about ensuring that Kenyans are safe. However, we are seeing so many substandard drugs in the market. So we are seeing many Kenyans, probably they might not be able to know that this drug is substandard, but according to Auditor General and also the report that was released last week, we are having so many fake substandard drugs, including ARVs. So I don't know what the government is doing in regards to this. We are talking about reduction of new infection. If a person takes a HIV drug that is fake, how do we reduce infections? And lastly, to Dr. Mercy, what is the status of release of money to private sector? They are complaining about late payment of SHA to the hospitals. What plans do you have? And so far, which is the leading between the private and the public? Which is one of the areas that you've released the money? Thank you.
Thank you, Angela. And Bwana Waziri, Angela has been polite, but, and I think the media here would corroborate, when you call some of the heads or sagas, they'll tell you they need permission from Waziri, written permission, for them to speak to us and give us any feedback. Like, we andika barua, have it delivered, alafu akiniandikia nijibu, then I'll answer. So I think in this digital era, Bwana Waziri, and also to the COG, we need to find a way of digitizing that approval processes, because we understand, officers will need approval. But is there a faster way other than andika barua, deliver SHA, iende kwa waziri, ndio tupate permission for our questions to be answered? Angela, you are very polite on that, but I know that's the experience you have. That's the experience most of us have had.
Thank you. Good morning once again. This is Dorcas Odumbe, Health and Gender Editor at Nation Media Group. I think my colleagues have asked basically the questions that I've wanted to ask, but I would just like to make a comment. Bwana Waziri, I hope some action is being taken, especially in regard to the fake drugs that are in the market. On the question of, Mercy spoke about going to Malindi and paying for a card. So she's a CEO, SHA, so she's aware that she's not supposed to pay. What happens to my mother in the village when she goes to the clinic and she's asked to pay and she pays? Is she aware that that's a criminal offense? So how are we doing public sensitization for Kenyans to know that they're not supposed to be charged? Because they go to hospital and they pay. There are two Marys, so I'm talking to the Mary of the COG. There's currently the ongoing nurses' strike, and you say that just a few counties, but even the few counties matter because those are Kenyans who are affected. And I'll give the example of Isiolo, where even the doctors have been on strike for more than 2 months now, more than 60 days. We don't know what the situation is. Kenyans out there rely on us as the media to tell them what is happening. So we'd love to know. We wouldn't want to just brush it off. The way you say that, everything is, we're getting everything sorted out. What is the current situation? If Isiolo, the doctors, imagine a hospital without doctors and without nurses. What is happening in those hospitals? Then the same nurses, at least I edit the stories quite a bit. I'll not be in the field writing the stories, doing them, but Angela and Helen and everybody else, they bring me the stories, so I am quite alert on what's happening out here. So now, regarding the current strike that has been ongoing, some of the stories I've been editing, I see the doctors, I see the nurses asking that health, the devolving of health to the counties is not helping them. And they've been requesting Waziri to take back the health docket. I don't know what you have to say about that. I think the question on fake medicines, Angela asked. And for Mercy, with the love from me and all my colleagues from the media. When we ask these questions, we are just asking from a place of public interest, not out of hostility, because our work is to inform Kenyans, educate them, and we would be very happy to see SHA working, would be very happy to see Waziri succeeding, and we'll tell all those beautiful stories. So anytime we write something that you think is not right, probably many times it's because the Helens and the Angelas and the Mercies have called and there was no response. So what we do in the story is say we reached out by the time we're going to press, they never got back to us. But Kenyans need to know what is happening. Thank you very much. And for this forum, I'm happy, and I hope we get to do more of this. Thank you.
I'll take the last one from CEO. You know, he was my former boss. So let me have him answer or give a comment, and then we answer those ones.
Good morning.
And then we take the next round.
I'm Charles Otieno, Managing Editor, Standard Group. We are the Bold. So, my question to Mercy, Shah. Now, I want to look at her straight in the eye and say that journalists ask intelligent questions. Number two, and I'm standing upright. I like when I discuss with as people who represent the Fourth Estate. I like talking to people straight.
Yeah.
And in the Standard, we do not shy. Yeah. We are very bold. Our writers here do not ask silly questions. We ask right questions and intelligent questions, and our job is to shape the narratives for the nation and the country. Now, I hope you withdrew that statement.
On her behalf, she withdrew, she apologized. Even the minister apologized on her behalf. So let's tell you
Apology
there.
accepted, journalists?
Apology accepted.
Is it accepted?
Okay.
Okay, now we can
Let's rest it. Now we move on.
Now we can move on. Now we can move on.
CEO Kemsa amesema usiweke headline.
Now we can move on. Our job here is public trust, and what we do with the media is to make sure that we give you information to the public, what you give us, Waziri. And we appreciate the Ministry of Health for what you've been doing. Our question is that sometimes what journalists are saying, that the answers do not come real time. And we need these answers real time, and in the space we require them at that time. That's what Dorcas is talking about. That's what Mercy Kahenda is talking about. That's what Gloria is talking, Angela is talking about. My question is to the blood transfusion in Kenya. What is the data? Why are Kenyans told whenever you are sick to come with a pint? What is the resource for the blood bank in Kenya for Kenyans to be at a safe space? Are we selling Kenyan blood to other countries? Number two, Dr. Luga, you used to be on this side. What has changed? Is it government speak? Are you looking at the...
Maybe you should tell me what has changed.
We will come to you. Kenyans, the doctors, you said there are many unemployed doctors, but if you go to facility, in my village in Ugenya, there are places where we do not have enough doctors. Number three, what is the Vision 2030 achievement in health, and where are we going? Asanteni.
Thank you. Thank you, Charles Otieno. So the questions are varied. We have questions to PPB on the issue of Ozempic, and I think the turnaround time on answering. You want to take that? Or do you have PPB in there?
I think we can have questions that belong to the DG, and especially any question on technical issues, cancer, menstrual situation, PPB. Then we have a question on the state of devolution report, where SHA on the delivery of mothers, and Awene, county government, and Dr. Bashir. Then there is also the issue of the status of mothers who are refugees and those who do not come from this country equally. Issue of NESP and donor funding cuts. We also have returning the healthcare docket back to the national government. Maybe Waziri will be able to answer that one. The last few questions equally. The issue of employment of workers, Vision 2030 achievement, and Blood Bank.
Who wants to go first? County?
I think let me also be bold. The standard is bold. As head of this ministry, I'm also very bold, and you people know that. So when you tell my CEOs you are bold, then I'm also very bold. But let me start with what this editor from Nation and her team. I think there's nowhere I have said that I must sign when you ask questions. And these good people will agree with me. When they send me questions, I answer. Where's Mercy Kahenda of Standard? Yeah. She sends me, Angela. But our problem is one. We have a feeling that you media want to divide my house. So that my CEO will give, my director will give an answer, and then you look at an answer given by the president, an answer given by the minister, and then you twist it. So we have agreed we are going to have, and from today we are going to have a communication one-stop shop. From today. And PS Olugwa and PS, we must have. The way we have one stop for all questions and answers from Parliament. We have liaisons in MOH who will answer petitions, motions, questions. That goes through the PSS, it goes to the DG, the PSS, it comes to me, I sign. So we'll have the same. Because we are accountable to the people of Kenya. And the media is there in existence to hold to account those who hold public offices. I have worked in Parliament for many years, so I know I have worked with the journalists. We will answer questions. And if you are from the Cancer Division here, and if you are from the National Cancer Institute here, you must provide cancer data to these good people by end of tomorrow. The same, I think, was cancer, breastfeeding. And I want to thank first the Nation Media, because they carry, I think, weekly features on health. So if we give the data, it's fine. But Angela, let me also say, you came to my office, I answered all the questions, but your headline wasn't what I said. Let me be very honest. Whether maybe the gracious lady sitting next to you maybe has changed. You know, the power moved. The headline and the story inside are different. I'll give it, yeah. And I want to thank the gentleman from Standard. At least Standard don't change. They don't change. But Angela, you came to my office. Let me give a good example. In my office, we sat for more than 2 hours. I answered all questions. In the morning when I woke up, and I usually don't sleep until I see the headline. There are people who sleep. As a good minister, I don't sleep. So that as when I see the headline, I prepare. I start preparing for a response. So I usually respond to your headlines the next day. Very rarely do people in government do that. Am I right? Because what you write. So also, when we give you data like today, please challenge us on the data. And between yesterday and 10th of August, if I'll be in this ministry, working with you people, we will give the people, all of us work for the people of Kenya, am I right? You people must check us, I agree. You must oversight us. But when we give you the right data, either the county government or the national government, like Jaramogi is good, you say Jaramogi, but rarely you tell me, I ask you, which facility? Then you say, no, we don't want to disclose the facility. So how do I answer that question? Because if I'm given the facility, I'll ask Mercy, I'll ask COG, and say facility X is doing this. That's it. So I think you are right. We must give you the issue of devolution, strides, and skill delivery. I think Mercy will talk about. I think PS Oluga and COG will speak about the latest equipment program. Then DG will speak about HIV and all the whole space of. But let me speak for Pharmacy and Poison Board. I don't know whether the CEO is here or these people are here. Yeah. Pharmacy and Poison Board will. In fact, the word poison must be removed. I want to remove that word poison. It doesn't argue well. You know, so Pharmacy and Poison Board was one of the state agencies that required reforms like yesterday. And I'm happy to report today that the board, led by a chair, and the management are people who are competent and who are working for the people of Kenya. Over 2,000 products, we have removed it from the system, which were counterfeit, which were fake. Am I right? 2,000? 2,000? 2,300. And the people who were importing went everywhere. They even talked to the media, but we stood firm. We've made sure that Kenya attains ML3, which was a mirage, by October this year. I think the last mission is coming next month. Am I right? Yes, the first week of September. Kenya has a huge manufacturing space. I mean, if you go to the one in Kilifi, Revital, it exports to India, it exports to the US, it exports to Europe. We have also stopped giving parallel importation permits. Am I right? Yes. Because people are bringing substandard drugs. People are bringing drugs that could affect the health of our people. Finally, Anthony did not ask you, you know, and my good brother from Standard, you know, I apologized, Mercy has apologized. You know, hii kizungu si yetu. So we have replaced it with the factual. So please, that one, tuko pamoja. Yeah. You know, we are a group that respects. But Anthony did not ask, you know, these characters out there, they are talking of 104 billion on this digital superhighway. And I want to ask here, and the accounting officers are here, where is 104 billion found in any of the budget estimates in the last 4 years? There's nowhere. So the element of government funding does not come in. The whole system has been built under PPP, and I think it's fee for service. I think I've explained. Finally, I think vision, somebody said Vision 2030. Yeah, tomorrow we are going to discuss Vision 2060. So it's a good question. Vision 2030, where is the place for health? Vision 2030 was started by a very good president, President Kibaki. President Kibaki wanted to implement universal health coverage the way he did for free primary education. And those of you who were then in the media, you remember there was Ngilu Bill, which when it went to cabinet, because of the cartels in the industry and many other people, that bill could not survive outside cabinet. I was a member of parliament. It died. So universal health coverage was not implemented. I'm just speaking the health sector under universal health coverage. Then comes President Uhuru Kenyatta. He wanted to implement universal health coverage. Mercy was part of the team. He started with 4 pilot counties of Isiolo, Nyeri, Kisumu, and Machakos. The same cartels couldn't allow president. And I was his leader of majority. And one morning he said, let's drop this thing. And we move on. But the bold leadership of President Ruto is today one of the signature projects and programs of this government anchored under Vision 2030. Housing was under Vision 2030. A better education model was under Vision 2030. Food security was under Vision 2030. Digitization of all government. Today, I think over 250 services, government services, have been digitized under e-citizens. All of us sitting here, as we sit here and listen to this, we are transacting on many platforms. All that have been achieved under, those are pillars and programs of Vision 2030. Now that they have been achieved under this administration, in fact, we can say that we are the ones who fully implemented Vision 2030. And now that it's coming to its own sunset days, that's why the president is saying, and visions don't belong to government. Visions belong to citizens. They belong to the private sector. They belong to the media. They belong to government. They belong to the farmer. They belong to the hada. They belong to the mama mboga. That's why the president is saying, as Kenyans, let us sit. And now that Vision 2030 sunset days are around, we plan for Vision 2060. So I think universal health coverage, and I think reducing maternal and newborn mortality rates in our country, making sure our mothers don't die, and we come to WHO numbers, making sure that all our hospitals are equipped and we reduce the referral and logistics pathway, making sure that health is universal, making sure that our cancer numbers reduce. And that's what this government is doing, is the attainment of Vision 20. If I go to education, I'm not the Minister for Education, but let me speak for him. I mean, you know, people were asking, how is this thing of the new higher education model going to be implemented? Where is the funding coming from? I remember I was in government, I was in parliament, not government, when President Kibaki was asked, how are you going to implement free primary education? It's expensive, it's this. He says, if you think education is expensive, then you try ignorance. That was the answer of President Kibaki then. So if you think, you know, this model of education, I think the bill is before parliament. I think it's called what? Something university funding, something private, bill. So I think I agree with you. That's why we are here as part of Vision 2030. What has this administration done to achieve universal health coverage? I think the rest, the rest they can answer their questions. I've only answered for
Yes, Waziri, I was hoping you will tell them also what has changed with me. Because, you know, you have to answer questions on my behalf, Waziri. But I think nothing has changed. I'm very passionate about healthcare. And What has changed is that I no longer have the mandate to call for strikes because I have been told to implement. And as you have seen, the doctors are happy, the nurses are happy, everyone is happy. So yeah, and no, it's true that there's been tremendous goodwill in the environment led by our Waziri here and His Excellency the President. It's in the last 1 year that we have paid 7.5 billion of arrears to doctors. 7.5 billion of arrears. We've signed CBAs for clinical officers, for nurses, for all health workers, and I think they know. And if you cover me well, I'm always in the hospital saying that the health worker is the system, that we put in the medicine, we put in the CT scan, we put in the equipment. Been on this space, but I wanted to answer the questions that we have on NESP, and I also want to give a lot of context. You know, I have the privilege of having worked in hospitals, and I know many of the hospitals that I worked. I worked in Kijabe, I worked in Outspan, I worked in Vihiga, and then I came to Kenyatta National Hospital. Now, many of our public hospitals, if you go there today, you will find the theaters are really run down. You will find many of the patients who require surgery have to be referred. You will find that the surgeons are not properly utilized because they don't have the tools. Now, if you look at the county budgets, you will rarely find opportunity for MCS to put money to buy equipment. To buy a CT scan of 200 million or an MRI of 300 million, or to ensure that the theater is properly equipped at 28 million. And it will always be story, and you, the media, will cover it. You will cover how the MCAs have not put a budget. And then the citizens will be talking to the governors. And then you will be talking about the cancer equipment in Kenyatta. You've written about that more than 5 times. Patients are in the line waiting because the cobalt machine is broken down. And you know what we suffer from? Number one, we suffer from a lack of a budget. Because for you to buy all this equipment for the public hospitals, you must tax the Kenyan. And number 2 is that even after you buy the equipment, you buy the very good CT scan, it's a problem. Why? Because we have equipment manufacturers. They come here, they give us a warranty of 1 year, then they service for 1 year, then they go back to Japan and they go back to where the manufacturer is. The skill to ensure that the equipment is properly maintained and serviced does not exist. Because technology for equipment changes very fast. That is why the government decided that instead of struggling to put in a budget, either by the county or by the national government, we are going to have the latest equipment in all our facilities. The patient will get the surgery. This equipment will only be paid for when the service has been offered. That is what we have done with Kenyatta National Hospital, where we have now put a new LINAC machine. That is what we have done with all these facilities, where Mwai Kibaki, where now we are now putting an MRI machine. And I'll just quickly, Waziri, in 1 minute, tell you, we have put 52 digital x-rays, not paid for, not procured. Of course, this was contracted by Council of Governors and the Ministry of Health, ensuring that there is value. Ultrasounds, 68. Mammograms, 6. CT scans, 36. 36 CT scans. You know, general theaters, 67. Dialysis, 25. Laboratories, 157. Specialized urology. You know, prostate cancer is top 5 of cancers. But you go to many of our facilities, we have trained surgeons, but they cannot do prostatectomy. Or they can do, but they have to take 6 hours opening it up because they can't do what we call TURP, okay? So neurosurgery, 4. The specialized maxillofacial, 8. Specialized cardiothoracic and vascular, because people have to come to Kenyatta just to get a clot removed from the heart. So we have put 4 of them, specialized plastic 4, and then radiation LINAC, I've talked about the one in Kenyatta, and also the MRIs where we have put 2 right now. And we are continuing. And the thing is that the citizen should not be denied a service because we are waiting for somebody to put a budget. Because you are waiting for somebody to put a budget. This is the whole essence of the National Equipment Service Program. And I'll finish it by saying, like, in many public hospitals, we have a 3 to 6 months delay in access to surgeries. We have theater lists that have not been tackled. And this is the problem. So many Kenyans are walking with diseases because the theater is not available. So instead of waiting for 20 years, 10 years for somebody to for county government hospital to put a budget, renovate the theater, put in equipment, why can't we help the Kenyan now? And I think if we understand it from that perspective, you will understand the National Equipment Service Program. You will understand it fully. The last thing I want to talk about is blood. I don't know whether Dr. Sirengo is here. Thank you. So I think DG will answer that question. So Mercy, please come and answer your questions.
Thank you. Thank you, PS. Now, last year in the extraordinary summit, His Excellency the President, together with 47 governors, gave direction on maternity services and their access in dispensaries and health centers. And right now, through an allocation of 2 billion Kenya shillings, SHA is able to pay for mothers who require to do deliveries in a dispensary and health center without the mother having to go into the pocket to pay for that. And so the challenges that were there before were sorted, and our mothers are now able to get that care. Now, in terms of registration, if we have any foreigner who is in the country, they need to register using what we call the alien card. If they don't have the alien card, then it means they cannot register for SHA. And the world over, I'm addressing the media and they're there. Right, so the world over, when you're setting up UHC systems, you have to look at the citizenry and those who are resident in the country. And for us, it's very, very pivotal, as engineer explained, that we are able to identify each Kenyan that is interacting with the SHA system. And ways of identifying the Kenyan is through the national ID. Ways of identifying anyone who's resident in Kenya for more than that 1 year is the alien card. For our refugees, they have a status card that we utilize for their registration. If they don't have an ID, unfortunately, they cannot access SHA services, because that's what we need to do to be efficient, to prevent fraud, and to be able to know who we are covering for. Now, teenage moms, mothers who are below 18, well, let's say 19 years of age, can actually access SHA through the issuance of a temporary ID. But because our digital system is so advanced now, by the time that mother turns beyond 18 and gets her birth certificate, we want to be able to have a system where we can actually match that mother to the resources that have been inputted in the system for her. So IDs are necessary. And our call to Kenyans is to get into the different registration centers and get your ID. The PS has been engaging the department, the registrar, so that we can do RRIs in the community. But an ID is something that we cannot relent on as SHA. It's needed for identification. Now, when we come to dental services, it is true. Dental services right now have not yet been activated, and purely it goes back to the envelope. For you to do a root canal on the street where Nairobi Hospital is, I think you know there's a lot of dental clinics there. Depending on the range and the doctor, you need about 800,000 Kenya shillings for a root canal, depending on who you're going to and the complexity of the root canal. What we're doing under SHA is under PHC. Basic procedures like basic tooth extractions, those ones are available. But as the dental procedures become more complex, For now, that is a component that we must go out of pocket for, because we've done our actuarials and the need for those dental procedures is not as big as the need for the PHC and other secondary procedures. A country must make decisions. Anytime where you have a limited envelope, you must have opportunity costs. As we continue building the fund, we will continue inputting more services. And we have a panel. I wish we knew, because today Prof. Jalko should have been here. Because then Prof. Jalko is the one who leads the determination of what the benefit package at SHA should look like. And he's currently doing a review process right now. He's completing on the 1st of October. He'll be bringing that report to the Cabinet Secretary. I want you guys to chase that report, because in that report there'll be good stories on what is new under SHA and what is out under SHA. And this story will be pivotal because there are some surgeries we will reduce the cost of. So there'll be noise in the industry very soon in October. Surgeons will be complaining, but then there'll be other people who will be saying the reimbursements are now better for certain procedures. So Kenya has put in a mechanism for determining what is in, what is out, and at how much. So in time, Prof. Jalko will go in and look at dental, even optical. We've heard people making requests for hearing aids. For you to do a cochlear transplant, if you need a cochlear transplant, it's 4.2 million in the cheapest hospital in Kenya, 4.2 million. SHA right now cannot afford that. But in time, as we continue introducing more resources into the fund and then doing the determinations through Prof. Jalko using HTA and other mechanisms, we will keep expanding the benefit package. There was the issue on where are we with the fraudulent claims. To date, and I think my CFO has left to go to a treasury meeting, but he was telling me we've done a recovery of close to 300 million to date in our finance systems, and we are still recovering more. The fraudulent cases in SHA are in different stages, and it's important we understand this. There's cases that are in the stage of investigation under DCI, and those ones are ongoing. There's cases that are under internal investigation at SHA, which then have two branches of action. There are cases that go into administrative action. There are cases that are forwarded to DCI. There are cases under ODPP, about 28 million, that are being engaged through ADR at the ODPP's office. What SHA has been able to recover from providers who've come back and said, you know what, you are right. Here's a check of 4 million. Here's a check of 3 million. Here's a check of 2 million. All those monies we've gotten back from providers are coming to 200 million that we've recovered from providers who've come and written checks to us saying, we agree, take back your money. So it's a continuous process as we continue reviewing issues of fraud within the fund. And again, I'm seeing Angela, I like reading faces. So Angela has a question. Just to define again, Angela, cases under DCI are still ongoing, not yet determined. Cases under courts, and I don't know if Terry is here, we have about 15 cases in the courts that are undergoing the normal court judiciary processes that will be determined by the judges. Then we have cases under ODPP that are going under ADR. Then we have cases where providers have come in, they've said, you know what, yes, take this back, that's about 200 plus million that we are continuously recovering from fraud. I'll come to you. We'll discuss, Angie, your next question. Now, the last bit that I wanted to talk to is on maternity services and late payments. We've talked about county governments and SHA owing county governments about 4 billion. Golda, I don't know what the number is, private sector? 22,
About 5.
And 5 for FBO. And that, remember, needs to be aged. Why do we owe private sector more? Because private sector actually claims more. If you look at the SHIF payments that we've done and you break them down through, I can see Golda on her computer, check. If you break them down through county, through FBO, through private, the private sector actually does more surgeries. The private sector actually does more bed days for high-cost cases. So even when we are paying out under SHIF, almost 57% of that goes to the private sector. So it makes sense that they would be owed more because they are lodging more. However, in PHC, it changes. In PHC, county governments take about 67, 68%, And then we have private sector and FBOs. So the two funds depend on the activity of what you're lodging as a claim. So I think with that, Waziri, Shara is done with this part. Yeah. Emma?
Okay.
Thank you very much. Thank you very much, Angela. The fact that you've actually crunched the numbers for the State of Devolution Address, we do not take it for granted. That you actually crack down the numbers. And these are not just the numbers, it's for purposes of information to the public. Yes, the skilled birth declined in the year, and Mercy has been able to explain the reason behind it. There was a policy pronouncement that our level 2 facilities were classified as not offering maternity services in the advent of SHA reforms and the like. But thereafter, we had an engagement with the head of state and the Ministry of Health, where we were able to present the numbers that skilled birth is declining as a result of this, because mothers had to walk kilometers and kilometers to go access this very extremely vital service to them. And this saw a policy change that was pronounced late last year, and I tend to believe this year numbers will improve. So the sole reason is for purposes of that, but that policy direction has already been corrected by the minister himself, communicated to all facilities, and I can confirm that level 2 across the entire country are offering maternal services across. So every mother should be able to walk into any level 2 and get free maternal services thereof. So yes, that is it. In terms of GOTRH, in terms of the NEST program, I want to say that the NEST program is a full package. It encompasses maintenance, reagents and consumables and placement. So if a machine has broken down, it is actually a matter of the facility in charge to just place a call, and the vendors will come, maintain them, service them, and provide reagents for purposes of continuity. I have confirmed, and CS, you may need to note that we have a forum that includes Mercy Mwangangi and Lenayara, and all the service providers and all the facility in charges, for purposes of ensuring that we unlock every SHA challenges, we unlock every digital challenge and every NESP challenge. All of us are in it, and I can confirm for the last 1 month that we've activated that forum. These people do not sleep. They offer, frequent responses and the like. I've actually engaged the in charge facility GOTRH, and it's confirmed that he's already engaged. And the in charge of NESP, who some of them are seated here, they are actually picking it to ensure that the facilities are, done. In terms of the health hiring and the like, my friend has talked about Ugenya. Let me confirm that hiring of health workers is not an instantaneous thing. It's a progressive thing. And equally in every civil service, you do not employ optimally. You continue employing on need, and based on the numbers that I've given in terms of the growth of facilities in this country, there has to be provision of resources for purposes of hiring more health care workers, which is a priority for purposes of service provision. So it's a continuous process, and hiring is on need basis. So some of these things will not actually happen instantaneously. A senior editor, my friend, it is actually progressive. So I think I want to rest at that. Thank you.
Thank you also to buttress on the Ewene, because Ewene came as a result of the stall in progress that as a global community towards reducing preventable maternal newborn deaths, and therefore we came with 90 by 90 targets and 80 by 80, meaning 90% of pregnant mothers ought to have a minimum of 4 antenatal visits, 90% skilled birth attendance, 80% postnatal care for the mother and the newborn within the first 48 hours, and 80% of the facilities being able to provide emergency newborn obstetric care services. As a country, we have made progress, but challenge still remains, and because we are having this conversation, it's only about 7 out of 10 mothers who achieve the required 4 antenatal visits. So we appeal to you to be able to help us advocate for mothers to be able to go for the 4 antenatal visits, so that we can be able to prevent these unnecessary deaths. In terms of skilled birth attendants, we are on track. I think it's at 89%. And if we continue maintaining the investments that we have made, we are likely to surpass that figure by 2030. Postnatal visit within the first 48 hours, we are at 78%, again on track as per the EWENE targets. And if we continue again, that target will be achieved and probably will surpass the target. We are making huge investments in terms of emergency newborn obstetric and emergency care through investment in equipment, distribution to the facilities, health workforce capacity building, and mentoring. Coming to the question of malaria. Blood. You want me to go for blood first? Okay. Blood, as a country in the year 2025, we collected 415,000 units. The WHO mantra is that a country should be able to collect 1% of its total population as its blood requirements needs. So our target that year was 550. We achieved 415,000 units. I can categorically state that we don't sell blood to anybody outside the country. And if you have evidence to that, please table the evidence so that we can be able to do the necessary investigations. We have also built that infrastructure for blood. We have the 7 regional blood transfusion centers. Garissa coming as the latest, about just 2 months ago, launched by the Cabinet Secretary to be able to support Garissa, Wajir, Mandera, Marsabit, and Tana River counties. And there's no single county in this country that does not have a satellite blood transfusion center. Further, as hemorrhage as one of the leading causes of maternal mortality, during the launch of EWENE, His Excellency committed a further 1 billion Kenya shillings to be able to strengthen our blood ecosystem. Availing these resources, we will be able to ensure that we achieve our target of probably 560,000 units. But as media, we need to be able to demystify one fact, that donating blood causes you no harm. We should be able to be altruistic to be able to donate blood, because there's no replacement for blood. As doctors, we have not discovered something that can be able to replace blood. So we need to be able to advocate for more Kenyans to come out and donate. We know those who have donated serially, and we recognize them during the World Blood Donor Day celebrations. So we need to be able to work with you to support us so that you can advocate for more blood. I just needed to provide clarity.
Short one, Bonadiji.
Yeah.
The question usually that comes from media is, donating blood is free, but when I go to the hospital to receive that blood, there's a cost to it. Why is that the case?
Because donation is just but one arm of the process, because that blood that you donate needs to be screened for what we call TTIs, transfusion transmissible infections like HIV, malaria, and syphilis. But that is a cost that the government bears. So you should not be charged for that transfusion, because that is part of this 1 billion that we are investing. And the annual allocations in terms of budgetary estimates to be able to provide blood at all facilities. The question about malaria, the figure is 4.1 million cases, and that figure came down from 5.5 million in 2023-2024 because of mass net distribution. And also we undertook a critical step in terms of vector control called IRS, indoor residual spraying, which we did in Homa Bay, we have done in Sia and Busia. And surprisingly, malaria cases dramatically reduced in Busia. We had to go and pick the malaria medicines to distribute elsewhere. So very, very good progress made in that prong. In terms of HIV, yes, adolescents and young people now account for nearly Adolescents aged 14 to 25 years account for 4 out of 10 new HIV infections. If you stretch that age to 34, they account for nearly 6 out of 10 new HIV infections. As a country, we have made progress in terms of the global 95 targets. We are 93 in terms of Kenyans knowing their HIV status against 95. We are at 91 against 95 for those who know their status, then going for treatment. And we are lagging behind slightly in viral suppression. Those who go for treatment, 95% of them ought to be able to achieve viral suppression. We are at 87%. These figures came down because we reworked our persons living with HIV population, which went from 1.3 to 1.4. And therefore, for adolescents, we are making targeted messaging. We are making it possible for you to be able to self-test in the privacy of your house. We are also introducing new molecules for control of prevention from the oral PrEP. Now we have the long-acting PrEP, which was introduced about 6 or 7 months ago, where you just require 1 injection every 6 months, and the uptake has really been encouraging. But we still have a problem with adolescents and young people. We have a problem with men, 1, knowing their HIV status, number 2, seeking treatment, number 3, adhering to the treatment as prescribed by the doctors. We also have a problem with our children, because children are usually voiceless. Let's all speak for our children, so that those who are diagnosed then are quickly put on treatment. Their parents or guardians ensure adherence, so that we can also be able to achieve the 95 targets for everybody. Well, there is nothing for us without us. We will continue in terms of our policies, technical guidelines, to be able to engage the adolescents in the development of these processes, so that we don't leave anybody behind. Thank you.
Thank you very much. Ladies and gentlemen, let's appreciate him. There are a bunch of Nairobi poets who once said, tuendelee ama tusiendelee. So are you ready for one more round of questions? Are you ready to ask one more round of questions?
We want to take
I believe you are.
3 burning questions. There was that
Awesome.
gentleman here.
All right.
There's a gentleman right behind here, and there was a burning one on this other side. So we'll only take those 3 questions. I believe that, during the answers by, the leadership, some of these things have been answered up and apale, unless you really need specific clarifications. So we'll just take those 3 and end the questions there. Go ahead.
Mine is not a question. Tusalamiane kwa hewa. Turn to your neighbor, tell them, at least journalists are intelligent. Turn to your next neighbor, tell them, at least journalists are intelligent. At least journalists are intelligent. Please.
No, we had closed that chapter. I don't want us to open it.
Listen.
I don't want us to open it, so just make the comment very brief because of time.
Mercy, my name is Wanyama Wachebusiri, a former BBC journalist and a member of the Kenya Editors Guild. As a senior member of the Kenya Editors Guild, I have to talk about it, Mercy, sorry. Because, yes, and I'm not going to talk about it in bad light. Listening to all those speeches when I was seated there as a seasoned journalist and also as a consultant, there is what we call lack of media literacy among these officials. They don't understand how the media operates. Journalists, am I speaking some point? If only you knew, and the only other person who knows how the media operates here is Dr. Moth, perhaps politician and Dr. Aloga, and of course. And therefore, what I want to insist is the media is not a conveyor belt. So that today, even if a headline was to come out of this place pertaining to the small alteration we would have, you will not be surprised. So media literacy is very much key. What am I saying? As a ministry, perhaps you may consider that some people, or rather some senior officials here, must undergo some public media relations. It's very much important, I'm telling you. It's very much important and very crucial because this one will eliminate some of this myth that we have about the media. Like, for example, when the minister was saying, my sister there went to the office, and then the following day, the headline was too bad. If you understood how the media works, you'll not be surprised. Because the media, just like medicine, engineering, we have our own way of doing things, okay? And we don't operate in a vacuum. We operate within the ethical considerations. And lastly, as the Kenya Teachers Guild, we were a bit concerned, for example, at the ministry level in terms of communication. When at some point, Mr. Minister, we know, we love you, but at some point, there has been some consistency in terms of confrontational and at times that borders on bullish tone on journalists. It doesn't augur well. And you know what? That overshadows all the good things that the ministry has done. So let's take on that. Thank you.
Thank you very much, Wafula. Bonaziri, I'll give you time to just comment on that later. I want to take one last one and another last one here.
Okay, thank you for giving me this opportunity. I am Samuel Do Ouma, health and science journalist, and also an editor with Health Business Magazine. I have two questions. The first question is for the DG, and it's on MPDSR, since Eweni has been discussed here at length. So the question is, we have a system of investigating maternal and perinatal deaths known as MPDRS. But why do we still have these preventive deaths while every day, every morning, the officials are being told on what happened and what causes those deaths, yet the gap still is there? Specifically, on the MPDRS, the issue that comes out each and every time is an issue of referrals and emergency transportation, that is maybe the ambulance services. Recently, you launched the ambulance, the 922. How is this going to fix the problem that you people get every day in those reports at MPDRS? That's my first question. The second question is on implementation gap that I just bumped into when I was doing some story on a neurosurgery procedure. I will read it because I'm not a medic. I'm not very intelligent on medic things. So it's called endoscopic third ventriculostomy with choroid plexus culturization, that is ETV-CPC. It is covered under the benefit package number 344. Just to show that I did some research. So on this, the benefit package is capped at 208 Kenya shillings, and it's a procedure to fix hydrocephalus. So one, there are very few facilities in Kenya, like 3 that I know of, that offer this service. One at Kijabe, I think one at the coast, and I think one is in Nairobi. That fact alone shows that patients have to travel in all corners of this country to come and access that care. And that brings about the hidden cost on maybe the transport and accommodation if this patient and the caregiver has to sleep. That is one gap on the hidden cost. The second gap in that coverage is that imaging and scans are only capped at, I think, 4 per year. Yet, this is a lifelong condition that requires frequent imaging, frequent scans, and frequent examinations.
Okay.
The last part is that this condition is not included in the chronic package benefit list.
Okay.
So, and it is a chronic condition. So there is a gap.
All right.
And just to get a comment on from Dr. Mercy, because when I reached out to Kijabe Hospital, the matter was even complicated because the neurosurgeons at Kijabe told me that there is a directive from SHA telling them that they don't offer this ETV CPC, but they do shunt. But shunt sometimes, according to studies published in the medical journals, is not very effective as this ETV CPC. So,
thank you.
The question is, when? Oh, okay. He has also alluded that maybe in October there will be a review. But can we be communicating to maybe Kenyans so that we know that maybe there is a shift? For example, when you go to a service provider at the Kijabe, they tell you that they will not provide this.
There because I think we have gotten the gist of the question, and Dr. Lesan will be answering
Thank you, thank you,
Thank you
Mercy.
very much for that elaborate. And
one final question, please.
I'm Elizabeth Atieno from TV47. My question is on family planning. So what is the supply versus demand gap when it comes to family planning in the country? How much does the government need to bridge this gap so that we can have adequate supply of the family planning commodities? And lastly, the ministry was expected to disburse 250 million to KEMSA by June, just so we can have a streamlined supply of family planning commodities, but there was a delay. What has caused this delay? Thank you.
Thank you. Thank you for being very brief. The last one. Very last one.
Thank you. I'm also going to be very brief. It's working. Okay. So I'm also going to be very brief. I've actually rounded my questions to one.
I can't hear you.
Can you hear me now? Thank you. Yeah, thank you. So my name is Chris Finn Magak. I am the digital editorial lead for MediaMax. I was saying I'm going to now round off all my questions to one, and thanks God because it's coming at the very last point. Listening to everybody, every submissions that we've had here, led by Waziri's presentation, you realize that actually SHA is to some extent working, or a lot of things in the health sector is working, but if you go to the ground, you see a debate where people ask questions, is it really working or not? So my question is, as a government or as a ministry, what is the challenge that you guys have in communicating all these progresses and bottlenecks to Kenyans, even beyond the media? Thank you.
Thank you very much. So I may not answer for the government, but I can't say this, that my name is Dr. Misheni. In 2024, I was a medical intern. I had just finished med school, and I was really looking forward to beginning my journey as a doctor. And unfortunately, we were held back for a very long time. We were held back. Remember those doctors who slept outside MOH? I was one of them. If you remember, I was there. Yes, we were there. If you remember correctly, even more, Dr. Mike Misheni and two others took SRC to court to complain and to really take them to court over what was happening. That was in 2024. That didn't happen in 2025. That did not happen in 2026. So they're doing well in some aspects, and I really love your question, and I hand it over to them to continue.
Thank you. So I think we start with thanks, Dr. Misheni, for confirming that interns are no longer sleeping at the gates of MOH.
Yeah.
So we'll take with Dr. Lesan or Oluga. Okay, you'll guide on the ETV.
Yes, please, Dr. Lesan, proceed.
Yes, good afternoon. Yes, my name is
Dr. Lesan, you come here.
Yes, good afternoon again. Yes, my name is Dr. Lesan Joel, Senior Director, Clinical Officer, Clinical Services, Kenyatta National Hospital. I'm a surgeon by training. So he's asking about a procedure that is struggled to mention it. But basically, it is for treating those people who have got problems with flow of the CSF in the brain from one chamber to the next. So initially, in the old method, a shunt would be put from the head to the abdomen. And that would need to be revised, particularly if you're a child, as you grow up, because the length of the body increases, so you have to keep revising it. But instead of that, what one can do actually is just to put a shunt that will drain from the front compartments, the rear compartments, just minimally, just making a small incision, probably passing through the nose, and then just putting a shunt in there. That, of course, is an advancement. It's minimally invasive. The duration of stay in the hospital is very short. The pain or the struggles that the patient has to go through is also minimized, which is an advancement on its own. It, of course, requires more advanced technology. That means the hardware that you put in is much more expensive, and probably that is why you found it at Kijabe or any other hospital. But I'm happy to say that Kenyatta National Hospital has got it. We use it for training with the University of Nairobi as well. So we have it at Kenyatta National Hospital. It's a procedure that we carry out now at Kenyatta National Hospital. When it comes to payment, what Mercy talked about is the ICD-11 coding. So once you identify the disease and you have the terminology right, then you can match it now with the SHA and actually put your claims through. So there should be no trouble about it, so long as it's a condition that is known. Where it has not been included or where you find challenges getting it on the SHA reimbursement services, then that is now where the Professor Jaogo's team comes in and is under revision. So you appeal into that section. But in the meantime, you actually get paid for that. So we don't have a trouble with it. It's a matter of terminology and putting it right. So you get a reference number and you get paid.
Thank you. So I think for the members of the public and the media is that Kenyatta National Hospital have all of these procedures. Often we think that these procedures are only in specific facilities. And again, it relates to the last question because we have not come out to unpackage what procedures can we offer at Kenyatta, at KUTRH. That's why we are here. Guys, I want us to calm down. We are here because we need each other. Are we okay? We are here because we need each other. And we are here so that the public can know the things that are important, which we can't tell them. You are the ones who can tell them. So if we came here and we spoke and you didn't tell them, then I want us to agree that even for you, you shall have somewhat not met that responsibility as a Kenyan, that you had some very useful information that could help a Kenyan somewhere. You knew it as a journalist, as an editor, that you know very well there's a mother who is suffering, that there is a patient who can get this procedure from KNH. We told it to you, but you chose not to tell them. I think there may also have to be some moral, just a moral obligation. Anyway, DJ.
Thanks, Samuel Doe, Dr. Samuel Doe, for that question. This is one of our accountability frameworks, MPDSR. Unfortunately, we have not made progress, especially in the perinatal, the P, and the response. So we are glad that now we are on the right trajectory. It's one of the accountability frameworks. The counties, I want to congratulate the counties because they have institutionalized this framework. And now we have what we call inter-county MPDSR. We have a weekly webinar where counties are able to discuss cases, showcase best practices, and that is the best way to go. Then in terms of family planning, yes, we have one of the oldest programs in the region. Our family planning program started in the 60s. Our demand, unmet demand, is 14%, meaning we cover 86% of the population needs. And in terms of availability of the products, KEMSA CEO is here. There's an ongoing procurement of 500 million shillings to be able to buttress our commodity security. Finally, His Excellency the President committed during the launch of Irene to allocate 2.5 billion additional resources for family planning to ensure that we meet our annual need of approximately Kenya shillings 3 billion. Thank you.
Thank you. Thank you very much, DG, Dr. Amoth, and thank you, everyone. Part of the reason we were here to have all of this conversation is a precursor to the Kenya Health Summit, as you can see on the, the banners we have here and some of the roll-up banners. And I want to show you a brief video and invite all of you as my colleagues in the Fourth Estate to be part of the Health Summit next week, to do media coverage. As you've seen, there's an open call from the ministry, from COG, for you to reach out. Also do the mystery shopping so that you can give the feedback, because at the end of the day, it's you and I that benefit. So I just wanted to show you something brief. So in short, those are the key discussion points that will be happening on the summit, the key reforms that have happened in the health sector. You can pick any of those topics. My favorite is usually the healthcare at your doorstep, because when you interact with the community health providers, they give you real feedback of what's happening on the ground, whether these reforms are working or not. And most of the times, they'll tell you of stories of people whose lives have been changed just because community health providers have been able to reach out to the community. Bwana Waziri, thank you so much this is the first ever media town hall that we've had. I've seen people, they've sat throughout the 3.5 hours. Yourself, you've sat throughout the 3.5 hours. With Oluga, we've come a long way back in the trenches. And the ministers then would just come, give a speech, go, or do 5 minutes, 10 minutes, and go. So we thank you very much that you've been very open. I'm happy about the Communications and Media Liaison Unit. So I'll follow you up so that you share that information with us, so that the Fourth Estate, the media here, know who and where to reach out for when they are looking for any information on the media. Misheni, just say your name.
My name is Dr. Misheni. Very happy to have been your host for this morning. Thank you for your attention and also for your lovely, lovely questions.
And mine is Dr. Mercy Correa. I've been your host. Thank you for honoring our invite. Allow me to welcome Dr. Oluga to come and we close this session.
Thank you so much. I just want that we give all ourselves a round of applause for wonderful discussions. I think, as you have noted, health is very broad. The issues are very personal. They can also be very emotional. We, as a government, are intent not just on answering your questions, but answering. On 19th, the health discussion continues.
Thank you, PS. Please, let's be seated. I think it was a very good morning. It's one of the best days I can say, because we have explained ourselves. And I want to urge my team that I have a very long history with the Kenyan media. And my brother, the consultant, the way you people ask questions is different. So also allow me to answer the questions the way I want. That's found in the Bill of Rights. So you can't tell me this is your scheme of work. And I'm sure you guys also have. All that we need to do is to make sure we work together. If I am asked today by a Kenyan in the street or anybody, Minister, tell me 1, 2, 3 things why you feel the administration of President William Ruto should be given a second chance. I'll start with health. And by the way, numbers and data don't lie. We will provide data, we will provide, whether it is in health, whether it is in agriculture, whether it is in education, whether it is in food security, whether it is in infrastructure. I was telling somebody this morning that even removing the railway from where it ended somewhere in Naivasha to Malaba was done by this government. Building the Rironi Mau Summit, building the biggest ever road in the region from Isiolo to Mandera, 750 kilometers at a cost of 100 billion. Making sure 32.2 million Kenyans as of today are registered with SHA. They don't need to carry an NHIF sort of a card. They don't need to carry an MRI documents, all their data. They just walk to a facility. The doctor doesn't need to be there physically. In 1.5 years, SHA, you know, I was wondering, there's a world of difference between SHA and SHIF. SHA is the institution. SHIF is a premium insurance, social health insurance fund. It's one of the funds. You know, I could see somebody yesterday was struggling between SHA, SHIF, SHA, SHIF. SHA is the name of the institution where Dr. Masi is the CEO. SHIF is like the primary, is one of the funds. In fact, we have got 4 funds. We have got Primary Health Care Fund, we have SHIF, we have ECCF, and we have the PMSF. Today, 178 billion has been paid to our health facilities. If it was for NHIF, good people, NHIF used to pay quarterly about between 5.5, 5.6 billion. SHA pays annually, monthly, by the 14th. I think Mercy has how many days? 3 days to go. 12 billion. So if you divide the 178 billion of 1.5 year of SHA existence to the former NHIF, is like 6 years, former NHIF will pay what SHA has paid in 1.5 years. Today, a mother can walk to a facility, level 2, level 3, level 4, deliver, go home. There's a whole program for teen mothers under SHA, paid for by the government, the equipment program. So I think I agree with you and the media, and let me assure you, at least for the Ministry of Health, let me assure you, I think it's good I have met Shikanda today. Physically, I have seen her, you know? And I don't know why, you know, in nation media, the tough ladies are there in that corner. So today I've even known your boss. Well, the person you take so I can assure you, I am going to put a strong communication team at MOH, a one-stop, I'll do it. You know, all these agencies have got communication people who I've never seen. PSS, first I want to have a meeting with all the communication teams at the Sagat. We form one because as a government, as a ministry, there is a moral, constitutional obligation that we must answer all questions asked by the media, by other stakeholders, by the citizens. And we must answer and give the right answer. What the media will do with that